This is Mehul Mankat. I'm a staff psychiatrist at the Durham VA Medical Center and an assistant professor of psychiatry at the Duke University School of Medicine. We're going to be talking about traumatic brain injury today. So for the first time in American military history, 90% of the soldiers in the OIF, OEF, OND theaters survived their combat injuries. Due to the excellent work of combat medical teams and the changing nature of warfare, more American troops returned home than compared to prior conflicts such as the Persian Gulf War, Vietnam, or older combat eras. And just as a comparison, if a soldier was wounded in the American Revolutionary War, he had about a 60% chance of survival compared to the extraordinary survival that our military experiences today. However, this increased survival does not mean that our troops return home without injury. It really just means that they survived their injuries. Our role in serving veterans is to identify the extent of their lingering injuries and aid them in maximizing their function in their daily lives. Some of these injuries are mechanical and are readily apparent. Other injuries are unseen and require more investigation to understand, and traumatic brain injuries fall into this second category. A medical definition of this phenomenon first involves exposure of an event that was traumatic to a person's head. Now, this might sound obvious, but it's an important first step. There are 4 ways that a blast or an explosion can cause traumatic injury to the body. First, let's start with a basic anatomy lesson. If you think of the head in 3 layers, it might help understand what's going on. Of course, on the outside of the head, there's the skin, the skull, and other layers of protective tissue. And then right in the middle is the brain itself. And in between the brain and the skull is this thin layer of shock-absorbing fluid. A primary blast injury involves a high-pressure shock wave that comes from the blast itself. So in a primary blast injury, the brain is just sitting here in this fluid, and it hits the skull at the point of impact. Sometimes the blast is so strong that the brain bounces off the skull and the opposite side of the brain also takes an impact. This bouncing around of the brain inside the skull is called a Coup contrecoup injury. And it can help explain why the symptoms of traumatic brain injury can be so global. Lots of different parts of the brain can be affected as a result of a TBI. A secondary mechanism of injury comes from debris or shrapnel. Now that debris or shrapnel can be penetrating or non-penetrating. A third or a tertiary mechanism of injury is physical displacement by the blast. So if the service member is exposed to a blast and is thrown against a bulkhead or hits their head on a hatch or any other solid object, then that can cause a TBI. A quaternary or 4th type of blast injury involves other physical injuries caused by the blast to other parts of the body, such as burns, inhalational injuries to the lungs, or other wounds sustained from the blast. We're actually not going to be talking about quaternary blast injuries today. So there are different levels of traumatic brain injury, and they range from mild to moderate to severe. And let's take a closer look at these groups. A lot of the classification of traumatic brain injury comes from information gathered in the first few minutes to the first week after the event. Clinicians who rate traumatic brain injuries look at the level of consciousness after the head trauma, the amount of amnesia or the difficulty remembering after the trauma, the degree of disorientation immediately after the trauma, and the presence or absence of abnormalities on scans such as CT or MRI. They rate all of these factors on a grid and come up with mild, moderate, or severe TBI ratings. Unfortunately, they are extremely common for U.S. service members, including those who are never deployed. But let's take a closer look at those who were deployed. Among those who were deployed to OIF and OAF theaters, the incidence of TBI is about 10%. Now, about 75% of that 10% of service members suffered a mild TBI. Another way of looking at this is that 10% of those who served in OIF and OEF come back with some sort of TBI, but 7.5% of those who served in OIF and OEF come back with a mild TBI. So that means about 2.5% come back with a moderate or severe TBI. Since most of the TBI that OIF and OEF service members experience is mild TBI, these symptoms may not be necessarily apparent while they're in the field, and it can take some time to figure them out. The brain is an incredibly resilient organ, and it can take a considerable amount of damage before it shuts down completely. However, even small amounts of damage to certain regions of the brain can decrease its optimum performance and can be readily apparent to the veteran, their family, their friends, and their employer. Remember, we talked about the brain essentially floating around in this protective fluid within the skull, and when the initial blow from the TBI happens, the side of the brain that's closest to the blast suffers the first injury, and if the blast is strong enough, the brain ricochets across the skull and the opposite side is injured. A common sort of injury involves a service member facing forward, and when they receive the initial blast, the frontal tips of the brain get the first impact, then the brain is forced backwards at high speed, and the back part of the brain receives the secondary impact. So you can see how completely separate parts of the brain are affected by one blow. The frustrating part of this for veterans and their clinicians is that the symptoms of traumatic brain injury can be incredibly diverse. Let's take a closer look at the common symptoms of TBI. We can group TBI symptoms into three categories. Physical symptoms of TBI. These can include headache, dizziness, blurred vision, balance issues, light and sound sensitivity, insomnia, nausea, ringing in the ears, also called tinnitus. Cognitive symptoms of TBI, those can include getting tired easily. You can go ahead and call that fatigue, poor concentration, attention problems, memory problems. Emotional symptoms of TBI. These can include depression, anxiety, and reduced tolerance to stress. Let's add a little bit to the emotional problem list. Think for a minute about the physical and cognitive symptoms of TBI. Somebody with TBI may become depressed or frustrated because of their constant headaches or because of their memory problems. Or they may become depressed as a direct result of the TBI on their brain. Right now, it's impossible to say in a veteran what the specific cause of their emotional problems is, so there's a little bit of a chicken or egg here. As we were talking about earlier, TBIs commonly, but not exclusively, occur during deployments, and as a result, TBIs occur during stressful times and can often meet the criterion A stressor for PTSD. So there can be a huge overlap between TBI symptoms and the symptoms of mental disorders. When a veteran walks in with depression, anxiety, insomnia, irritability, anger, concentration problems, fatigue, or avoidance, should we jump to the conclusion that they definitely have a mental illness? It may not occur to the veteran that some or even all of their symptoms could be related to a traumatic brain injury. It takes careful evaluation, often performed by clinicians from different fields of medicine, to sort out what's going on. Now let's say a diagnosis has been made by a group of trained clinicians. Now what? Well, it's important to understand that exposure to rehabilitation and treatment has value in helping the brain return to its highest level of function after the trauma. And the sooner the treatment plan can start, the better. Because symptoms of TBI can be so diverse, it's important to create an individualized treatment plan to address each cluster of physical, cognitive, and emotional symptoms. So if one veteran has more physical symptoms, maybe they'll be spending more time with the neurologist or the speech pathologist. And if another veteran has more emotional and cognitive symptoms, they may be spending more time with the psychologist or psychiatrist. One thing that we really don't want to ignore is the functional impact of TBI symptoms. Clinicians are great at treating symptoms, but what we really need to do is look at the big picture. What about things like job placement or educational aids or supports? What about housing, finances, legal issues? What about family and friends and caregiver burnout? Don't underestimate the impact of these real-life effects on someone's recovery from TBI. As a veteran service officer, you are in a unique role to coordinate and connect veterans with TBI to these community resources. Thank you.